Welcome everyone to our webinar series. Today we have the honor of having with us Dr. Danielle Andrade, and she's going to talk to us about epilepsy genetics for the adult neurologist. Dr. Andrade is a professor of medicine and neurology at the University of Toronto in Toronto, Canada. She is the medical director of the epilepsy program and the founder and director of the Adult Genetic Epilepsy Age Program at Toronto Western Hospital, University of Toronto. She is the co-chair of the International League Against Epilepsy Task Force on Transition of Patients with Epilepsy from Pediatric to Adult Care. Finally, she is appointed board member of the ILA North American chapter. Dr. Andrade's research interests are in the field of genetic epilepsies and the long-term outcome or natural history. Her team identified several genes associated with epilepsy, including the first gene associated with SUDEP, sudden unexpected death in epilepsy, in patients with non-syndromic epilepsy. Her team also discovered genes responsible for different epilepsies, including Lennox-Gastaut syndrome, Gibbon's syndrome, teenage onset neuronal ceroid lipofuscinosis, and progressive myoclonus epilepsy. Without further ado, we give our kind welcome to Professor Andrade. Thank you very much for being with us.
Very much for this invitation. It's a pleasure to be here to talk to you about genetic epilepsies. Can I start by sharing my screen? Okay, let me know if you can see my screen.
We can.
It's not in the, okay, let me just, it's in the right mode. Is it the right mode? Or you're seeing the little slides?
No, it's perfect.
It's okay, good. So thank you very much again. I prepared this talk to be a very broad talk about genetic epilepsy for the adult neurologist. I don't have time to cover every single aspect, but I want to give you a good sense of different things that are important in dealing with patients with genetic epilepsies, okay? So let me go to my disclosure slide. And here's the outline. So first of all, we're going to cover some basic concepts. Then we're going to talk about the adult phenotype of one particular developmental and epileptic encephalopathy. I'll talk about Dravet syndrome. I thought about talking about some other ones, but I don't think we're going to have time for that. And then finally, I want to talk a little about genetics of common adult epilepsies. So why do we need to know about genetic epilepsies? Is this something that affects only children? Well, no, first of all. And even if it is, I mean, if you look at children with epilepsy, those that have what we used to call symptomatic epilepsies, only 19% will have some kind of remission. The remission rate for the epilepsies without other neurological issues is a bit higher. But overall, 50% of children with epilepsy will still have seizures as adults. So let's move to the first basic concept. I think it's very important that this is clear. We have germline mutations and we have somatic mutations. So germline mutation means the mutation happened in one of the gametes, either the sperm or the egg. And then when these two get together and start to form the embryo, all cells of this embryo will carry the genetic abnormality. And this is the kind of genetic abnormality that you can detect by a blood work. So patient has an epilepsy, the problem is in the brain, but you do blood work and you can detect the genetic abnormality because this patient has what we call a germline mutation. You have other types of mutations, and you have the somatic mutations that happen a little later. So the egg and the sperm are normal. And when they fuse together and start the embryonic process, one cell gets mutated, and then this will lead to mutation in a group of cells, but not the entire body. So that happens, for instance, in patients that have some genetic epilepsies that we will not detect by doing blood work, but you will only detect if you actually look at the brain cells. This has been very nicely shown on this work from Dr. Puduri's lab, where you see areas of cortical dysplasia. You see patients with hemimegalencephaly. So depending on what part of the embryonic stage the cell got mutated, you're going to have a larger or smaller area of cells affected. The next basic concept I think it's important to understand is the difference between monogenic, oligogenic, and polygenic epilepsies. So in the past, we thought of epilepsies as being caused by trauma, stroke, cancer, infectious diseases, and the rest of the epilepsies, about 75%, we didn't know what were the cause. We suspected they were genetic, but we really didn't know. And they were called idiopathic. Now, we know, well, first of all, for the structural and other causes, we added autoimmune epilepsies, which is a very big field today. And we also added focal epilepsies with structural changes that we now can detect on MRI. And some of these are genetic, some of those are acquired. But the rest of the epilepsies, and we are talking about 70%, they have a very strong genetic component. Some of them are caused by a single gene disorder. So just having one gene mutated is enough to give you the epilepsy. Some are caused by a combination of a few genes, so what we call oligogenic epilepsies, and others are caused by a very large number of changes in a very large number of genes, all of them with a small effect. I'll talk a bit more about that towards the end again. Just to exemplify, so you have the rare epileptic encephalopathy. In this case, I chose SCN1A, where to actually identify a new gene causing a rare epileptic encephalopathy, all you need is a single patient. If you have a patient and you find a mutation in a gene and you know the mutation is severe enough, you know the function of the gene, you can do some functional assays and you can tell, okay, this is the gene causing this form of epilepsy. Then you have certain epilepsies that run in families, either focal familial epilepsy or generalized familial epilepsy. And they are caused, again, by a single gene. What happens is that most of the times the gene is private to that family, and many other families will not have the same gene, even though they might have the same phenotype. Then you have patients with rare forms of epilepsy, often associated with ID and autism, where this is caused by a copy number variant. So a chunk of the chromosome that is either deleted or duplicated. And you have your common garden variety, generalized epilepsies, focal epilepsies that are caused by changes in several thousands of areas of the genome. So polygenic. Just to add a way of finding this, so most of the de novo mutations causing epileptic encephalopathies have been found by next generation sequencing. Most of the familial ones have been found by linkage. The copy number variants can be found by FISH, chromosomal microarray, and more recently through whole genome sequencing. And for the common genetic epilepsies, we need thousands of patients and GWAS studies to help us calculate polygenic risk score and things like that. Next is the third basic concept. I think everybody's familiar with that: autosomal dominant, autosomal recessive, X-linked, and de novo. So autosomal dominant, you just need one copy of the mutation to cause the disease, and you have the issue of penetrance. So take, for instance, tuberous sclerosis. Very often we're going to have a patient who has tuberous sclerosis, whose carrier mother or father do not have many symptoms or have a very first form of that syndrome. Maybe just a few skin lesions or maybe just a few hematomas. So you can have a much milder phenotype in a relative depending on the penetrance, but it's still an autosomal dominant. Autosomal recessive is where you need both copies of the gene have to be mutated to express the phenotype. That's the case for the majority of the progressive myoclonus epilepsy. Take, for instance, Lafora disease. You need mutated copy from the mother and one from the father to actually manifest the disease. Otherwise, you're just a carrier. Then you have the X-linked diseases, where females will usually be carriers, or they will have a milder phenotype and the males will have the full phenotype. Remember that females have the random X-linked inactivation. So if you have a patient with a female patient with a mutation in this X-linked gene, this patient might have a more severe phenotype if most of her X-linked inactivated, most of her X chromosomes that were inactivated are the ones with the wild phenotype. So all that she's expressing, or the majority of what she's expressing, is the mutant copy. But if by random chance, the majority of the inactivated X chromosomes are the ones that have the mutation, then she'll have a phenotype that is closer to normal. The other thing that is important to remember with X-linked is that some conditions, such as periventricular nodular heterotopia, called by FLNA gene, the women might have the FLNA the periventricular nodular heterotopia, but their male child will have a much more severe form and may not survive. So that's something important to keep in mind for X-linked diseases. And then finally, you have de novo. De novo are those diseases which are manifested in the child without any of the parents carrying the abnormality. So what happens is the abnormal gene appeared in one of the gametes, so as one or just a small group of the sperm or the eggs had that mutation, or during very early embryogenesis, the mutation happened, and then this mutation is now present all over in all cells of this patient. Okay, so now we know about the basic concepts, why it's important for the adult neurologist to know about genetics. This is a research we did several years ago where we asked the level of comfort of neurologists treating different forms of epilepsy. And we compared the adult neurology with the adult neurology specialized in epilepsy, that's the ANE, with the pediatric neurology and the pediatric neurologist specialized in epilepsy. And we noticed that the areas where the adult neurology was more uncomfortable were for patients that had malformation of cortical development other than regular cortical dysplasias, patients with epileptic encephalopathies, and patients with epilepsies associated with genetic syndromes in general. The other thing is, for people of my generation, this is the kind of adults that we saw when we were training. So you had that pediatric patient that had epilepsy. This patient had MRI, EEG, and then you found out that he had, for instance, temporal lobe epilepsy or genetic generalized epilepsy, or a low-grade tumor, or some form of malformation of cortical development. And you knew how to treat this adult that had this kind of etiologies. Then you had a group of adults that was coming to you that had seizures since very early in life. And they did get what I call the $1 million workup. At the time, they got karyotype, metabolic tests, biopsies, and no diagnosis was made. And they come to us with a diagnosis of quote unquote symptomatic epilepsy. These are patients usually with very severe epilepsy, in addition to intellectual disability, autism spectrum disorder, sometimes motor, speech, and other abnormalities. Well, the thing is, with next generation sequencing, now these patients who were the so-called symptomatic epilepsy patients have a diagnosis. And they come to us as young adults with SCN1A, PCDH19, CDKL5, CHAD2, STXBP1, and I can keep telling you the names of genes and more genes and more genes that are associated with this, what we used to call symptomatic epilepsies. But we need to learn about them because they are different. Each patient is different from the next, and we need to learn about those conditions. For this reason, we're going to talk about developmental and epileptic encephalopathies, and it's important to keep this in mind. The concept of DEE is that the epileptic activity itself contributes to severe cognitive and behavior impairments that are above and beyond what might be expected from just the underlying pathology. So sometimes you have a patient that has a small cortical malformation but has significant ID and ASD and significant seizures that are bilateral. It doesn't really explain the small area of cortical malformation do not explain the whole phenotype. So think of this as a young developing brain who is having many seizures. Those seizures will damage the development of this brain. So developmental and epileptic encephalopathies are not synonymous with genetic epilepsies, but they represent a large group of them. But they can be caused by hypoxic ischemic events, by, like I said, malformation of cortical development, either genetic or acquired, by specific genes, single gene disorders like Dravet syndrome caused by several genes, mainly SCN1A and these other ones here, or by haploinsufficiency or duplication. So 22q11.2 microdeletion is the most common copy number variant that we see in patients with epilepsy. Next few slides are going to be about Dravet syndrome. Patients with Dravet syndrome, they do not have any neurological abnormalities when they are born. They have a normal development until shortly after the seizures start. The initial seizures usually are febrile, but they can be afebrile. Most of the time febrile, and they have not only the first one, but several in the beginning of the disease associated with fever. They tend to be generalized tonic-clonic or hemiclonic seizures, usually starting between the age of 6 and 18 months of age. And the patient is usually normal between seizures. However, they start having afebrile seizures of all kinds, tonic-clonic, atypical absences, multifocal, and myoclonic. Now remember, myoclonic are very important. Dravet syndrome used to be called severe myoclonic epilepsy of infancy. Of course, because these patients don't magically improve after infancy, the name wasn't the most appropriate, and Dravet syndrome is better. And of course, Dr. Charlotte Dravet, who described this patients initially, now carries the name of this syndrome. So myoclonic seizures are an important part of the phenotype in children. Patients tend to have clusters of seizures and status epilepticus. They can be very common, very frequent, especially in the first decade of life. There is a high mortality, especially from SUDEP and status epilepticus. And even though they were born without neurological problems, as they get older, you start to notice learning disability, neurodevelopmental delay, and eventually they become adults with moderate to severe intellectual disability. The period of active seizures tend to end at different times, but usually after the age of 10 to 13 years, they start to have less seizures. The seizures become a little more manageable. They don't become seizure-free, but the seizures become a little more manageable. The myoclonic seizures and the atypical absence tend to disappear in adults with Dravet syndrome. So if you have a patient who was not diagnosed as having Dravet syndrome during pediatric years, there's a chance you might not see the myoclonic or the absence in the adult, so you actually have to ask the parents to see if those were present in previous years. Many adults will be less sensitive to fever, but they can still have fever-induced seizures. Most adults will have convulsive seizures restricted to sleep, so that's something important to ask the parents as well. The episodes of clusters and status epilepticus are less common. They can still happen, but they are way less common in adults. Well, how do we treat patients with Dravet syndrome? This is the algorithm that was produced by the North American Consensus in 2017. At that time, we didn't have CBD and fenfluramine approved for Dravet syndrome. We are now doing a second consensus where these drugs will be included, so they may go up here somewhere as first or second line. But right now, I'll tell you what the algorithm is without those two drugs. So first line is valproic acid or clobazam. Second line is addition of stiripentol or topiramate or ketogenic diet. Third line, addition of clonazepam, levetiracetam, zonisamide, etosuximide, for the absent seizures only, phenobarbital or vagus nerve stimulator or deep brain stimulator. The important thing is that you should avoid sodium channel blockers. So remember, the majority of patients with Dravet syndrome have a defect on a sodium channel gene, is the gene coding for the alpha 1.1 subunit of the sodium channel that is defective. So if you block the remaining sodium channels that are working, you're going to make this much worse. And we know that patients that were exposed to contraindicated medications tend to have a worse cognitive outcome as adults. I did put an asterisk in phenytoin because phenytoin may be actually the only drug that will stop status epilepticus. So it is still used, and most child neurologists will say we can still use phenytoin for status epilepticus, but definitely is not a medication that should be used routinely for the prevention of seizures. Now, treating adults with Dravet syndrome is a little more challenging, especially if they did not have a diagnosis as a child. In our service, we had a number of patients who were not diagnosed as Dravet when they were young. And you can see in this graph on the left side, we have the green triangle representing the age where seizures started, and all of them had seizures between 0 and 1 year of age as expected. The red X represents the age of diagnosis, and all of this represented here had their diagnosis after they came to the adult service, so after 18 years of age. And the blue diamond represents the age at which they started stiripentol. And you see that in some cases, there was over 5-year gap between having the diagnosis and starting stiripentol. And this is because several of these parents were already somewhat traumatized by previous experiences with changes in medication. Especially the patient didn't have the correct diagnosis. It's very likely that this patient was exposed to sodium channel inhibitors in the past and had a worsening of seizures. So these parents are somewhat concerned with further change in the medication, and they compare the seizure frequency of the adult child with the seizure frequency when they were very young. And of course, they were having more seizures when they were young, but they're not seizure-free yet. Anyways, in this group of patients who had a late diagnosis, at some point we started stripentol, and patients had several side effects as listed here. Most of the side effects are side effects that you see with any anti-seizure medication, but increased seizure frequency was something curious, and we thought, could there be something metabolic going on? And we tested for ammonia, and turned out that even though we had decreased the valproic acid and the clobazam, because remember, stripentol interacts with those medications, so we had to decrease the doses of valproic acid and clobazam. Still, some patients who were on valproic acid had increased levels of ammonia. Well, when we treated the hyperammonemia with carnitine, the side effects disappear. So the side effects that were attributed to stripentol, they actually went away when we treated the hyperammonemia. We were able to keep stripentol, and we were able to keep the improvement in seizures, and the side effects went away when we treat with carnitine. Having said that, still we could not reach the same dose that is recommended for children. So in children, usually you can go up to 50 milligram per kilogram per day. In our adults, we went up to 16 plus minus 10 milligrams per kilogram per day. So in a few of them, we could get to half of what the children use. But it's important to know about stripentol if you have an adult that is stripentol naive. Well, in addition to seizures, this patient have other problems. And one of the significant non-seizure manifestation is gait. Not only gait, so they have speech disability, intellectual disability, autism, ADHD is common in children, not so much in adults. And in terms of gait, you have the Parkinsonian, the dystonic, and the crouch gait. Here's an example of crouch gait. You can see the patient has hip and reflection. No. So no spastic hip and knee flexion. It's very typical of patients with Dravet syndrome, but they also develop other problems. Like I said, we realized that our young adult patients had a lot of Parkinsonian manifestation, like when they were walking, they had small steps, they turned on block, postural instability, rigidity, bradykinesia, hoarding, antecholis or chin to the chest, like this patient in pink here. PISA syndrome, which is the inclination to the side, or camptocormia. We treated some of these patients with levodopa, and we saw a mild response in some of them. So it's an option, it's something to consider. The gait is very abnormal, and it might be one of the most difficult things in adults with Dravet syndrome, even though seizures were the most severe problem where they're young. As seizures settle down a bit, gait might be a significant issue. And in fact, we look at the gait of patients with Dravet syndrome using instrumental gait analysis. And we did this study during the pandemic. So we had to use historical controls. And here's just a sample of a few of the things we observed in these patients. And in most gait modalities, they were doing worse than the control group, and the control group were patients of 62 years of age. So even the youngest of the Dravet patient, the 18-year-old, has a gait worse than a 62 healthy control, and their gait tends to get worse as they get older. Okay, so I will stop talking about developmental and epileptic encephalopathies here. Dravet was the only one. Let's move on. Focal epilepsies, and I will start with autosomal dominant nocturnal frontal lobe epilepsy, which is now one of the she epilepsies, the sleep-related hypermotor epilepsies. So ADNFLE was described back in the 90s, a very large Australian family with several affected individuals. That was the first gene associated with epilepsy was found in this family, CHRNA4. But turns out that only 10 to 15% of the families with this phenotype will have mutations in this gene. And this is what we see for most of the familial syndromes. It's a small group of patients that will have mutations in genes that we know. So some of the genes that you will hear are, of course, the CHRNA4, DAPDC5, KCNT1, which can cause other conditions as well, CHRNB2, and a few others that are more rare. So let's focus on DAPDC5. This is a gene associated with focal epilepsy that you will hear a lot. So you can have patients with mutations in DAPDC5 that have familial focal epilepsies, that have familial focal epilepsy with variable foci. This is a very interesting condition where you have several people of the same family that have focal epilepsy, but the foci is variable between individuals. So you have one person with frontal lobe seizures, someone else with temporal lobe seizures, someone else with parietal lobe seizures. It's not like the seizure is changing in location in the same patient. It's different location in different people from the same family. You can also have autosomal dominant focal epilepsy in general, or nocturnal frontal lobe epilepsy, like I mentioned. Focal cortical dysplasia is something that is seen in some patients that have DAPDC5 mutation. And it's interesting because it's a slightly different pattern of FCD. It's the bottom of the sulcus cortical dysplasia. So you can see here in this MRI, it's really at the bottom of the sulcus. You have to be careful to look for this kind of cortical dysplasias in patients carrying this abnormality because they might be surgically treated. And in fact, there are some reports that suggest that patients with DAPDC5 focal epilepsies tend to have a good prognosis after epilepsy surgery. Interestingly, the focal cortical dysplasia in these patients is caused by what we call a second hit mechanism. What is that? So they have a germline mutation. So every cell of their body will have one of the copies mutated. So remember, you can do blood work and see that this patient has a DAPDC5 mutation. However, those cells that are part of the cortical dysplasia, if you look at them, those cells will have both copies of the gene abnormal. So the second copy, the one that was normal, suffered a second hit, and now both copies are abnormal, and this cell is associated with the cortical dysplasia or the other malformations of cortical development. DAPDC5 might be related to SUDEP. So we described the first family of SUDEP cases in patients with non-syndromic epilepsy, and it was associated with SUDEP. Those are autopsy-confirmed cases of SUDEP. Further research later showed that SUDEP is a candidate, that DAPDC5 is a candidate gene for SUDEP. Some people may say, well, it might be just because DAPDC5 is a very common gene, seeing several forms of epilepsy. It might be, but it might also be that it is indeed related to SUDEP. So the jury is out yet for this. We have to be careful and attentive. DAPDC5 is part of a group of other genes that inhibit the mTOR pathway. So they're called gator or gator pathies. these genes are associated with several forms that we see regularly in the adult epilepsy clinic. So sleep-related hypermotor epilepsy, frontal lobe epilepsy, focal epilepsy unspecified, less commonly in temporal lobe epilepsy, less common in focal febrile seizures, but again, 10% of patients with infantile spasms and 4% of generalized epilepsy. The structural changes that you might see, so some patients, like I said, will not have any structural changes, but those that have, they can have some form of malformation of cortical development. Focal cortical dysplasias type 2A, 2B, and 1 are the most common, associated with the second hit, as I mentioned. They can have hemimegalencephaly, subcortical heterotopia, and even hippocampal sclerosis. Okay, moving on, our beloved temporal lobe epilepsy. So this is the bud and bread of the adult neurologist. And you might tell me, well, temporal lobe epilepsy is associated, it's an inflammatory condition. We know about this, it is inflammatory. Well, there's this very interesting paper that showed, that studied 129 human hippocampi of patients with temporal lobe epilepsy. And gene cluster analysis showed two different clusters of genes. One of these clusters actually did increase the expression of proconvulsant inflammatory proteins, including interleukin, TLR, and TNF alpha. So yeah, that makes sense. And it's interesting that when the researchers did animal models, zebrafish models that were further stimulated with PTZ, pentylentetrazole, to increase seizures, those that had a wild type did have more seizures, but those where this gene called sense3 was knocked down, they had less seizure. So why is this important? Because sense3 might be a target for gene therapy for patients with temporal lobe epilepsy. So very important to keep that in mind. We might hear more about the seizure in the next few years. Okay, so now we are getting to the genetic generalized epilepsies. Again, bread and butter of the adult neurologist. Most of the cases, people will say, well, it's genetic, but we don't have a gene. And recent research has explained to us why. About this family since the 90s, where you have a very large family with several people affected by some form of genetic generalized epilepsy, where you had one predominant gene, most often one of the GABA receptor genes. In those families, you would have sometimes people with childhood absence, others with juvenile myoclonic, others with just generalized tonic-clonic seizures. But those genes that were found on these rare families, if you tested those genes in people without a strong family history, you would not see that they were abnormal. So something was missing there. In addition, lots of studies with monozygotic twins showed that the concordance rate for GGEs was as high as 80%. So if one twin had a GGE, the other twin would have it in 80% of the cases. But again, it was very rare to get one single gene that reached any statistical significance. So what we know just in the last few years is that patients with GEEs, as well as many forms of non-acquired focal epilepsies like temporal lobe epilepsy, what they have is a high genetic burden of mutations. What does that mean? It means that they have changes in several areas of their genome that are associated with a decreased seizure threshold. So if you get a large group of people, and this was done through several GWAS studies, you can tell who has a risk of having epilepsy versus who does not have a risk of having epilepsy. So, like I said, common and generalized epilepsies can be associated with genetic variants of small effect size. Then you might ask, well, if the variant has a small effect, how come the patient will develop the phenotype? Again, because you see this change not in one single gene with a small effect size, but in several. We don't know if it's hundreds or thousands, but definitely several. So this study done in 2019, they looked at, and again, to do this kind of study, you need a very large population. So thanks to the EP25 consortium, the ILAE consortium, there were 12,000 patients that could be studied versus 24,000 controls. And it was observed that on those patients that had between 50 and 60,000 SNPs, they were more likely to have seizures. And this effect was so large that was equivalent to a monogenic epilepsy. Another way of telling you this is like, for instance, you know, patients with BRCA1 have a very high chance of having breast cancer. Patients that don't have BRCA1, but have a very high polygenic risk score can have the same chance of having a breast cancer as someone that has a BRCA1. So for epilepsy, we came to the same conclusion. So if you have changes in several genes with a small effect, then you can have, the addition of all these changes can have a strong effect that is equivalent to having a monogenic epilepsy. Okay, we're coming close to the end. I just want to have a quick word about genetic testing for epilepsy. Who should have genetic testing for epilepsy? Patients that have drug-resistant epilepsy without a clear etiology. So if it is a patient that is said to have brain palsy, but you do the MRI, there's no really any structural changes, that might not be really a cerebral palsy. A patient that just don't have any clear, obvious reason and have drug-resistant seizures. Patients with epilepsy plus intellectual disability. In fact, we published a few years ago that 16% of adults with epilepsy and any degree of intellectual disability will have one or more pathogenic copy number variant. Patients that have malformation of cortical development, patients with progressively worse symptoms, think about progressive myoclonic epilepsies, and patients with dysmorphic or multiple congenital abnormalities, although it's probably best to refer those to a geneticist. Patients who should not have a genetic test, those that have common forms of epilepsy, such as generalized genetic epilepsies, or even pharmacoresistant temporal lobe epilepsies, especially if they are of normal intelligence, because it's very difficult that today we will find a cause for those. Patients that have clear structural lesions, so patient that has seizures because of a stroke, a cavernoma, or, I mean, you don't really need to do genetic testing on those patients on a clinical basis. Patients with well-controlled epilepsy. And then you might ask yourself, why would I do genetic testing in an adult? Why would that help me or help my patient? One of the reasons is for genetic counseling for siblings who might be of childbearing age. So that's a very important thing. I like to cite this example where we had a patient with a severe developmental and epileptic encephalopathy. At the age of 34 years, we made the diagnosis for him. He had a MACP2 duplication. When we did the diagnosis, his sister was pregnant and she did not want to know the sex of the baby. She and her husband were having a baby, didn't want to know. But when we found the gene, then they asked us, okay, but if I know if this is a boy or girl, could that change? Could I be passing this gene to my child? Well, MACP2 duplication came from the patient, and the patient's sister's mother. So the mother was a carrier. She has 2 X chromosomes, so she was asymptomatic, but the son who had the single X chromosome that came from her with the mutation, he had the full-blown MECP2 syndrome. So if this sister was also a carrier, and if she was pregnant with a boy, this boy would have a 50% chance of having a full-blown MECP2 duplication syndrome as well. So when we found the gene on the brother, we did test her. Luckily, she was caring for a girl, and now this girl will have to be tested eventually when she decides to have children. So it's important, even in adults, you can do genetic counseling for siblings. The other thing is social consequences. I have the permission to post this email from the mother of a patient that has PCDH19 epilepsy. She was saying that she has always been responsible for all the costs associated with her daughter, but since the diagnosis of PCDH19, the government agreed to pay 50% of her caregiver care costs. So it is important, even for social reasons, getting more resources for these patients, etc. In terms of management and diagnosis and management of comorbidities, it's important. So for instance, Parkinsonism, Dravet syndrome, schizophrenia in PCDH19, we showed not long ago that 15% of patients with PCDH19 will develop severe psychotic disorder. Many of them will develop schizophrenia. So instead of thinking, oh, my patient is just having post-ictal psychosis, think of schizophrenia. This patient may need a psychiatrist and long-term treatment. Think of clozapine-induced seizures in patients with 11.2 microdeletion. So in the general population, clozapine will cause seizures in about 1% of patients. If the patient has 22 deletion, the 22q11.2 deletion, 40% of them will have clozapine-induced seizures. So it's very important to keep that in mind. Again, it's important for precision medicine. Like I said, there are too many medications coming on the market now. Some of them already approved, many on trials for specific monogenic epilepsies. I put a few examples here, only like fenfluramine for SCN1A, ganaxolone for the DAPDC5, for CDKL5, sorry, it should be CDKL5. mTOR inhibitor drugs for the Gator, which then includes the DAPDC5, antisense oligonucleotides for some other forms of monogenic epilepsies, including SCN1A. And lastly, to avoid a lawsuit, because you should not keep prescribing contraindicated medications for some of these patients. Okay, moving to the conclusion. I hope it is clear for you now the differences between somatic and germline mutations. I hope you have a better grasp on the concept of monogenic versus polygenic epilepsies. For patients with developmental and epileptic encephalopathy, remember that the phenotype of the genetic epilepsy can change as the patient gets older. Seizures may even improve in frequency or severity, especially status epilepticus. We tend to see less status epilepticus in some forms of adults with DEEs, but these patients might have new neurological problems. We have to be careful. We have to also be careful with known epileptic events that might manifest as paroxysmal events. We sometimes need to bring these patients to the epilepsy monitoring unit to see if what they are having are a new type of seizure or something else. Keep in mind that psychiatric problems may be even more disruptive than seizures in some adults with DEEs. Remember that the Gator epilepsies, this is a name you're going to be hearing more and more frequently, are mainly associated with focal epilepsies. Some patients may have malformation of cortical development. there is a high SUDEP rate associated with gator epilepsies, and they might be the target of mTOR inhibitor drugs, so something to keep in mind. The second hit mechanism is something that can cause cortical dysplasia, at least in a group of the gator epilepsies. And finally, epilepsy tissue analysis keep on revealing new genes and new somatic changes seen on genes previously associated with a germline mutation. So I'm going to stop here, and I'll be happy to take questions. I know this event could not be done live, so you can always email me your questions. Thank you very much.
Thank you, Dr. Andrade, for this wonderful presentation, very comprehensive of what we should know about epilepsy and genetics. And I think you clarified many of the questions that sometimes neurologists, adult neurologists have. I do have one question or some questions. One is regarding the diagnosis of Dravet in adult patients. What would be like the clinical features or the tips that will make you suspect this is probably Dravet syndrome in an adult patient?
So because this patient didn't have a proper diagnosis as a child, and this patient was probably exposed to sodium channel inhibitor drugs, I tried to talk with the parents about how they reacted every time they changed the medication. That might be one clue. I think one of the most significant clues is to ask if the first seizures were febrile or not, and if they were hemiclonic or not. So that's something that can, parents many times will remember if the first seizures were febrile or if they were hemiclonic. The other thing is if they have Parkinsonian symptoms. We actually did a research comparing patients with Lennox-Gastaut syndrome and Dravet syndrome. And the majority of patients with Dravet had Parkinsonian features. The majority of patients with Lennox-Gastaut did not have Parkinsonian features. So that was something that helped us very much. Like I said, the presence of myoclonus is tricky because these patients might not have myoclonus anymore. They might not have absence seizures anymore. One thing that can help is that the seizures in the adult tend to be restricted to the night or to the time when they are sleeping. Even if they have a nap in the afternoon, they may have a seizure then.
One more question. Why would you recommend in adult neurologists who are receiving patients from the pediatric care? The pediatric neurologist has cared for them all their life, and then they are transitioning to an adult neurologist. What would you recommend do with these patients that have like intellectual disabilities, autism, for the adult neurologist? How can they approach these patients in a better way?
So first of all, I think it's very important that the pediatric neurologist sends you proper information. And when I say proper information, it's not a copy of all the charts since the patient was 2 months old. Honestly, in real life, we don't have time to go through the whole chart. So there is something called transition epilepsy form or epilepsy history form. We published this. I can send you the link later. Where you can have precise information of types of seizures, types of medications used in the past, side effects of those medications, why those medications were not used more, or they had to be stopped. Was it because they just stopped working or they had significant side effects? So there's a bunch of things in this structured questionnaire that the pediatric neurologist can prepare and send to you. It is important that to have many of the immediate things dealt by the pediatric neurology as well. For instance, power of attorney. So when the patient has intellectual disability and the patient goes to the pediatric hospital, no one questions who has the power of attorney. They will listen to parents or caregivers or whoever brings the patient there. If this is an adult with intellectual disability and they are brought to an emergency room, uh, the physician, the care, healthcare providers might ask for power of attorney. So that's important to establish before, or substitute decision maker. That's important to establish before the patient leaves the pediatric system. Things like school, like so special education school, housing for patients that will move to, for instance, group homes or things like that. All that should be dealt with in the pediatric years, because the adult, that is the time to do. Another thing is reconsidering the diagnosis. So for instance, patients that have had events their whole life and the events would change, and they have always been seizures, but they change. Sometimes they will change to some things that are not necessarily seizures. They can be stereotypies. So those things have to be reinvestigated either in the pediatric or in the adult system, but they have to be reinvestigated. Very important is genetic investigation. So if this patient had, like I said, the $1 million workup, but didn't have a diagnosis, repeat the investigation now. Our technology has changed significantly, and we can make diagnoses in a large number of patients that didn't have. We did a study not long ago again, where we did whole genome sequencing in 30 patients that did not have a diagnosis, despite even exome sequencing some of them. And you can make diagnosis in a large proportion of them. So it's always very important to reinvestigate these patients.
One last question. When should we refer the patient to a genetic specialist? What are things that make you decide to better use this resource when dealing with some patients with epilepsy?
So if the patient has multiple congenital abnormalities or dysmorphic features, it's more likely that the geneticist is going to be of better help. If it is a patient that you suspect might have a metabolic condition, again, you have geneticists specialized in metabolic diseases. And just if you're not comfortable with a genetic syndrome or a genetic diagnosis, you can always, or you should be able to ask the help of your geneticist colleagues. But I think more and more we will end up treating patients with monogenic epilepsies like DEEs. Without their help, they're also overwhelmed with all the other things. But definitely, if the patient has multiple congenital abnormalities and dysmorphic features, you should refer.
Okay. Thank you so much, Dr. Andrade, for this wonderful presentation. And we thank you all for listening to this webinar that we will post soon. And thank you so much. See you next time. Bye-bye.
Bye-bye.